let me start with Dr. Selva. Dr. Selva, you have worked as a health administrator in government for more than 2 decades. In your experience, what have you seen as the most significant barriers to equitable access, not just in the state, but in India? And what are some of the biggest success stories and lessons that you have learned that you can kind of share with our audience today to set the context a little bit?
Thank you. Welcome you all to India, Chennai. And I understand that more than 16 countries are represented in addition to the people from India. And thanks for AVPN for organizing this and giving an opportunity. As you rightly said, there are two things. One is your barriers. The second year, what we have done it right now. The barriers, as my understanding, the biggest barrier is the awareness in the community. It could be of many things. See, much of the previous presentation was talking about your non-communicable disease, where 65% of your morbidity, mortality is due to the non-communicable disease. The biggest missing awareness is your lifestyle modification. So lifestyle modification, which we talk about, the way we eat, the way we exercise, the way we take rest, this is all what determines. In fact, in our medical curriculum, we clearly define the difference between the medical care and the health care. The health is something, by definition, it's a state of a complete physical, mental, social well-being, and not merely an absence of disease, so as to lead an economically and productive life. This is just a bigger definition, more than a medical care. And also, we clearly define it has got a spectrum of activities, right? From promoting health, preventing health, early diagnosis, treating them, rehabilitation, disability limitation. It's such a wide spectrum where there are so many actors are there, and everyone, if you are able to do it, we can definitely do it. Going back, awareness, it's not only about the way you live, and also many times we are not aware what is actually happening in the system. See, that awareness is one thing. See, for example, in the state and central government, we have a scheme through insurance where most of the inpatient treatment is covered under insurance. See, the awareness is the one which is a big challenge which we need to take it forward. And another big thing is the trust in the system. See, there may be a little bit of negligence, there may be a little bit of errors, but if you lose the trust in the system, it will go to increase, providers will go for a defensive mode, the cost will increase, the legal litigations will increase, and your violence may come down. See, ultimately, it moves around the awareness, which is the biggest barrier which I feel, that also in a different system. And the success story means, again, I'll take the clue from your presentation, the non-communicable disease. It's a big challenge. And considering the size of the population, it is really a big one. And we have done a program called MTM, Makkalai Thedi Maruthuvam. That is, we reach those people at their home to deliver this non-communicable disease program. We launched 3 years back. Now we could able to reach around 2 crores. That is 20 million people were already identified. They are put on treatment, which includes nearly 1.2 crores. That is 10 million hypertensives and another 50 lakh, 5 million diabetics, and another 4.5 million will have both diabetes and hypertension. See, this 2 crore people, we could able to do it just through a volunteer, community volunteer. Though we have our own system of doing it, the volunteer is the one, the identified volunteer for every 5,000 population. We could able to reach them door to door, screen them. The suspected people will be referred to the nearby primary health center. The medical officer will confirm after diagnosis, put on a protocol-based treatment, and the medicines will be delivered once in 2 months to the doorstep of the individuals. So this is the way we operate. In fact, we got an UN award in last September, UN Assembly, for reaching this as a biggest among the 17 across the globe. This is the biggest achievement. Definitely, it will bring down the out-of-pocket expenditure drastically, and also it will bring down the complications which we expect. Will definitely bring down the complications, which is the another huge expenditure when you need to handle. It could be your cardiac problems, it could be your renal problems. All those things can be prevented if you are able to bring that control. Maybe I'll stop here. Those are things we can discuss.
Yeah, thank you, sir, for sharing that. And this very compelling model of bringing healthcare providers directly into communities. An interlinked challenge that we see, sir, is that not just here in Tamil Nadu but across India, is the presence of diverse healthcare providers who sit outside the government health services. And we know that patients often seek the nearest provider as the first point of care because it's easier to access, it's cheaper. So, in your very considerable experience, how have you engaged private healthcare providers, both formally and informally, to be able to sort of provide that standardized quality of care across these diverse healthcare systems?
It's good. In fact, health is handled by many providers, and when the country is developing, definitely it's the private sector step in. It's quite natural for any developed countries. And the government role we need to define in two ways. One is the service provision. The second one is the service regulation across the system. See, we not only provide service, but also see to that everyone provides a level at which those people who are downtrodden are getting the service. This we have done with our experience in handling our insurance scheme. We have done it through three activities. One is that we empanel the private institutions. See, during empanelment itself, we'll be clearly indicating who are all eligible, what is the minimal facility that should be available, and what is the qualification of the provider, and what is the SOP they need to follow. And in fact, we have linked their payment to these criteria. We graded them according to this so that there is an incentive for the private provider to ensure that a certain level of service is provided. This is the one part. The second part is that to ensure the quality of treatment, we develop an SOPs which is linked to the identification of the care system or identification of the beneficiary, and also whether the required treatment is provided or not. We could put on this part of this SOP and it is linked to the payment. See, by simply identifying the provider and also the identifying the way in which you need to identify the beneficiary and also the service provision, everything is linked, transparent, and is also linked to the payment. This is the one way through which we can improve the engage the private sector.
Yeah. Thank you, sir, for sharing. That's a very powerful framework that you have developed that can be applicable to a lot of different contexts. Anyone in the audience? Yes, we have Pritha right here up front.
Thank you so much to the panelists. I think it was very exciting to hear the interplay of the different roles you all play. We heard even in the opening keynote about the very high out-of-pocket spending in India. And of course, I know Tamil Nadu is a little ahead of other states, and we have new insurance schemes even rolled out to elderly over 70 recently. But just given cancer care in particular, given the burden of disease and NCDs overall, the cost of treatment and after treatment care is extremely high, and it's going to take several years for it to come down. So, would love to hear both, maybe starting with you, Dr. Selva, what's the government's point of view on out of pocket spending in the country? And also Takida's point of view, because as a responsible, like you said, values driven pharma company, where can you play a role in this, if at all?
Thank you for the question. Actually, as pointed out, the cancer is the one of the another non-communicable disease, which is epidemiology. It is increasing. Two things we have done from the treatment point of view. For all chemotherapy, surgical intervention, radiological interventions are all already part of our insurance scheme. where every individual in Tamil Nadu is already having a card. More than 85% is covered. They can get free treatment, not only in the government institution, but also in the empaneled private institutions. This is one part. But what we are trying to now do is that it is not only the treatment. See, we need to diagnose them little more earlier so that we can reduce the suffering of the individual. So for that, now we are moving towards what is known as an organized cancer screening. That is, those who are 30 plus, particularly focusing on three cancers: cancer cervix, cancer breast, and oral cancer. All 30 plus, irrespective of symptoms, they will be invited to the nearby PHC. We have around 2,286 primary health centers in Tamil Nadu. They will be invited. The preliminary screening will be done by our staff nurse. Once it needs a doubtful, the confirmation in higher institutions, and once it is confirmed, follow-up will be given by the insurance scheme. So this is the steps which you are taking on to take care of the cancer.
Excellent. Thank you so much. I know we have a big time's up flashing here in front of us, and we'll have a chance to go much deeper into some of these topics in our afternoon workshop today. But before I wrap up this panel, because the title of this panel is about calling this a joint mission, right? So before we end, very quickly, maybe in under 10 seconds from each of you, what would you say to our audience is the immediate next steps that we can take to build a cross-sector strategy for equitable access to health? Just one very quick next step for each of you.
Okay, time up. Yes, surveillance can be stepped up by everyone if you're contributing, including the community, private sector lab. And yes, COVID can be expanded into UWIN, where all your universal immunization can be, it's a part of it. And to work with the government, the root level village health and sanitation committee, which you're talking about, it's one day. If you want to work with the higher level, particularly on a digital health, there is always a support needed in the government. For example, I run around 2,000 institutions where lakhs and lakhs of people are getting benefited. See, even the drug distribution, how it needs to be done in every facility according to the number of persons, according to the treatment, which we need to monitor. This type of facilities are needed. And the one thing which I propose every plant therapist to do is that let us give them an annual screening, health screening for every individual possible. The basic few, if you are able to do it, support it, maybe in an area of your operation or your area, village, whatever it is, that's the biggest thing. The early diagnosis, it's a much needed, more comfortable, cost effective, and also less suffering to the individual. That is where when you do it. And finally, with madam from the pharmaceutical industry, our whole idea, if you want to reduce the out-of-pocket expenditure, it's a time we need to move towards the what we call it as a generic drugs where the quality is certified. That could be the another game changer. Thank you very much for the opportunity.
Thank you so much, sir.